Let us continue to the projections of the wrist. Examining the wrist, let us visualize the carpal bones and its joint spaces. We can demonstrate carpal fractures and dislocations in different projections. So let's start with the PA projection. The patient is seated at the end or beside the radiographic table with his forearm rested, and the wrist should be placed centered to the image receptor. Adjust the hand and the forearm to lie it in parallel with the long axis of our image receptor, and slightly arc the hand at the metacarpal phalangeal joints to place the wrist in close contact with the IR. The central ray is directed perpendicular to the mid-carpal area. This will visualize a P projection of the carpals, distal radius and ulna, but the ulna has a slightly oblique rotation and the proximal metacarpals. Center first the long axis of IR to the table and place the hand and forearms long axis in parallel with the IR. Center the mid-carpal area or the wrist joint to the image receptor. Flex the digits so that the wrist joint will be placed in contact with the image receptor. Here's the difference of not flexing the digit for wrist PA projection. You can see that there's a gap under the wrist area when the hand is positioned with its palmar surface down. When you flex the digits, this gap will be lessened and the wrist will be in contact with the image receptor. The AP projection of the wrist is almost the same as the PA projection. Instead of placing the hand in palmar surface down position, here the hand should be supinated. Place a support under the elevated digits to place the wrist joint in close contact with the image receptor. The central ray is directed to the mid-carpal area perpendicularly. This projection will better demonstrate the carpal interspaces. Now here's the reason why the carpal interspaces is better demonstrated on AP projection compared to PA. The carpal bones are naturally in concave position on its anterior side. Placing the hand in supine makes the anterior side facing the X-ray source or our X-ray tube. The beam divergence of X-ray will coincide with the joint spaces of the carpal bones due to its concave position. Therefore, the beam can pass through well these joint spaces and will appear open on the radiograph. Compared to when positioned for PA projection, the carpals were in convex position on its posterior surface. Thus, some of the X-ray beam divergence can't pass through the joint spaces as some of the rays may be trapped due to the convexity of carpal bones. For the lateral projection of the wrist, the patient could be seated at the end or beside of the radiographic table, with their forearm and arm rested in lateral position. To ensure that the ulna is rotated into lateral position, flex the patient's elbow 90 degrees. The central ray is directed perpendicular to the carpal joint. This will visualize the lateral projection of the proximal metacarpals, carpals, and distal radius and ulna. The lateral projection of the wrist can also be used to show fracture displacement and joint dislocations. The wrist has two positions for oblique projection. First is the PA oblique projection in lateral rotation. We have to position the patient's wrist with the palmar surface in contact with the image receptor. From this position, have the wrist be rotated laterally or externally until it forms an angle of approximately 45 degrees with the plane of the IR. We can also use a 45 degrees punch wedge to ensure the proper obliquity of the wrist. The central ray is directed perpendicular to the mid-carpal area. It enters just distal to the radius, which is the elevated side. This projection will visualize the carpals on the lateral side, particularly the trapezium and the scaphoid. To give more emphasis for the scaphoid, this projection has a modification in which the wrist is in ulnar deviation while having a 45 degrees obliquity from the IR plane. The next position is AP oblique projection of the wrist in the medial rotation. The wrist is rotated medially or internally until it forms a semi-supinated position of approximately 45 degrees to the IR. We can also use a 45 degrees sponge wedge support placed on the posterior surface of the wrist. The central ray is directed perpendicularly to mid-carpal area and enters the anterior surface of the wrist to a point midway between its medial and lateral borders. This will visualize the pisiform separated from the adjacent carpal bones and gives more distinct radiograph of trichotillum and hamate. The next projection that we have is a modification of the PA projection. It is the wrist in ulnar deviation. The patient positions the same as a PA projection, but the wrist is deviated towards the ulnar side. To attain this position, hold the wrist joint to keep it in place and move the elbow away from the patient's body and then turn the hand outward until the wrist is in extreme ulnar deviation. The central ray is directed perpendicular to the scaphoid, or it could be angulated 10 to 15 degrees proximally or distally for a more clean delineation of the scaphoid. This position will correct the foreshortening of the scaphoid. I place my hand and forearm diagonally to the IR so that if I deviate my elbow towards the body, it will be parallel to the long axis of the IR. When we say distal angulation, the central ray is directed towards the fingers, and for proximal angulation, it is directed towards the elbow. The other modification is a PA projection in radial deviation. The same with ulnar deviation, but the elbow is moved towards the body and the hand is turned medially until the wrist is in extreme radial deviation. The central ray is directed perpendicular to the mid-carpal area, and this position will visualize an open interspaces between the carpals on the medial side of the wrist. Scaphoid is the most common fractured carpal bone. That's why there are several projections that emphasizes it. One of the methods that is used to visualize the scaphoid is a Stetcher method, PA axial projection. The patient is seated beside or at the end of the radiographic table with the palmar surface down on the IR. One end of the IR is placed on a support and adjusted so that the finger end of the IR is elevated 20 degrees. The central ray is directed perpendicular to the table and enters the scaphoid. This method visualizes the scaphoid without self-superimposition. Another method for PA axial projection is the Bridgeman method, where the wrist is placed in ulnar deviation, but the image receptor end is also elevated at 20 degrees. Next is the scaphoid series, PA and PA axial projection, the Raffert long method. The hand is turned outward until the wrist is in extreme ulnar deviation without moving the forearm. This has 4 central ray directions, perpendicular, 10, 20, and 30 degrees cephalad directed to the scaphoid. In this case, the X-ray tube is directed towards the wrist of the patient. This method will demonstrate the scaphoid with minimal superimposition. As the tube angulation increases, the scaphoid is visualized without being overlapped by the adjacent carpals. The next projection is for the trapezium, a PA axial oblique projection, Clements-Nakayama method. The patient is seated beside the radiographic table with the hand in lateral position or resting on its ulnar surface. Rotate the hand internally to place it in contact with the 45 degrees sponge wedge on its anterior surface. If the patient is able to achieve ulnar deviation, adjust the IR so that the long axis of the forearm and IR aligns with the central ray. If the ulnar deviation is uncomfortable for the patient, align the straight wrist to the IR and rotate the elbow end of the IR and arm away 20 degrees from the central ray. The central ray is angled 45 degrees distally to enter the anatomic snuff box and pass through the trapezium. This method will clearly demonstrate the trapezium and its articulations with the adjacent carpal bones. The Clemens-Nakayama method has two positions. First is hand in ulnar deviation while resting on a 45 degrees box wedge, and second is the elbow end of the IR is turned 20 degrees away from the central ray if ulnar deviation can be achieved by the patient.